Hi, everybody, and welcome. It's so good to be here with you all. So in honor of Maternal Health Awareness Day, which is January 23rd, CarePlus has organized this really fabulous discussion on how an integrated approach to healthcare provides life-saving support for mothers and families impacted by mental health, addiction, and other social determinants to health. So by highlighting, we have 3 grant-funded programs operated through CarePlus here with us today. These are our in-house experts, and they will be sharing evidence-based practices and a ton of invaluable resources for perinatal mental health, trauma-informed services, and as well as compassionate approaches to addiction treatment. So we're going to introduce our experts that we have. We have representatives from the Bergen Trauma Training Center, the Maternal Family Center, and the Maternal Wraparound Program. First, we're going to hear from Jen Belton, who will tell us about the Bergen Trauma Training Center with a specific focus on approaches and initiatives to help maternal health. Thanks, Jen.
Awesome. Thanks so much, Maggie. Hi, I'm Jen. As Maggie mentioned, I'm with the Bergen Trauma Training Center, which is a 5-year federally funded grant that CarePlus has. We're in year 4. The overarching goals of this particular grant is to make our agency and our community more trauma informed. So it's a widespread grant, but it does join forces with a lot of our maternal and family programming because we want to ensure that all of our clinicians, our front desk staff, everyone that's working with populations that come through our door are trauma informed. And further, we want to take this information out into the community to link folks with services that may be beneficial to them. So the BTTC grant is really an umbrella and CarePlus items fall within it. Thanks so much, Maggie.
We're very fortunate to have you here. Thanks, Jen. Now we're going to hear from Sarah Boyages, who's going to introduce herself and her program as well.
Hi, everyone. My name is Sarah Boyages. I'm the Assistant Director for Outpatient Services here at CarePlus, and I work directly with the Maternal and Family Center, overseeing clinical and programmatic daily operations. Within the program, I also provide direct clinical care for our clients. So the Maternal and Family Center serves the mental health care needs for prenatal, perinatal, and postpartum women and their families. We provide individual, couples, and family counseling, as well as medication evaluation, medication management, and education. And we also offer a wide range of support groups and therapeutic groups. Our main programmatic goals include helping women improve their ability to cope and function in their daily lives, as well as help taking care of themselves, their babies, and their families. And we also really strive to raise awareness and increase access to resources and treatment within the community, providing community training and education and wraparound integrative care. So that's a little bit of a brief synopsis of the Maternal and Family Center.
Thank you so much, Sarah. We look forward to hearing a little more about it as we talk today. Now we're going to turn it to Tennille Jordan, and she's from the Maternal Wraparound Program here at CarePlus.
Hello, everyone. My name is Tennille Jordan. I am the program coordinator with the Maternal Wraparound Program. We support Bergen and Passaic counties. This is a statewide program, and what it is, it's a peer support program that provides intensive case management and peer support to pregnant or postpartum women struggling with substance use disorder. The program was actually started in 2018. At that point, it was exclusively for women impacted by opiate use disorder, but I'm happy to say that it has expanded since, and we are providing this service to women with any substance use disorder. MWRAP just really seeks to support women in recovery, even in the prenatal period. It is hard, I think, to access services sometimes, and we're here to offer that non-judgmental, non-clinical support and help them get to where they need to improve outcomes for themselves and for their babies.
Thank you so much, Tennille, and for all of you for being here today. This whole discussion is really focused on highlighting the importance of maternal mental health. And so with that in mind, we're going to lay the groundwork by introducing some relevant and important statistics regarding maternal mental health. And Sarah is going to begin to share with us now.
I think that maternal mental health is just overall a very treatment desert. It's really hard to find mental health care providers who specialize in maternal and mental health, even though maternal and mental health is very common. Currently, the current statistics are that maternal mental health conditions affect 1 in 5 women, and that comes to about 800,000 new parents each year in the US, which is obviously a very high number. And in terms of New Jersey actually ranks 47th for overall maternal death rate. In 2020, 28 out of every 100,000 births, the women, passed away due to the pregnancy or postpartum related complications. And within that number, women of color are actually 7 times more likely than white mothers to pass away. And 1 in every 3 women of color is affected by mental health conditions during pregnancy or postpartum. And when we talk about, maternal mental health conditions, we're really talking about these perinatal mood and anxiety disorders, otherwise known as PMADs. And these include perinatal and postpartum depression, anxiety, PTSD, and substance use disorders.
Wow, thank you so much, Sarah, for really shedding light on those powerful and strong statistics that are out there. And, we're all here to talk about how we can create integrative approaches to support these women. So Jen, we're going to start with you. We wanted to ask you, what are ACEs and PACEs, and how well are they understood for the perinatal population?
Thanks so much, Maggie. So ACEs and PACEs are very well understood in general, but I'm going to break down some information on them and then wrap it into how this affects parenting and the maternal health population. So what are ACEs? What are PACEs? ACEs stands for Adverse Childhood Experiences, and that's what I'm going to focus a little more on, but I would be remiss to say if I didn't bring up PACEs, because PACEs are the protective factors, and we as people are both the adverse and the protective factors coming together, and that defines, our experiences and how we navigate the world. So the PACEs are all the good things, and they totally exist, and we cheerlead them, and we come from that strength-based approach, of course, at CarePlus with all of our client interactions. But I really want to talk about the ACEs, the adverse childhood experiences, to provide some background and some context. And this is a very broad topic, but it touches each of us, and I'm not sure that folks realize that. So specifically, what are ACEs? What are adverse childhood experiences? So they fall into 3 categories. I think often we think of the abuse categories, whether that's physical, emotional, or sexual abuse. But we also have neglect, and that can be physical or emotional neglect. And then they have a category known as household dysfunction. So these are things like having parents with mental illness, having incarcerated relatives or parents, observing domestic violence within the household, living with substance use and abuse. And divorce and separation was part of the beginnings, the typical ACEs. More research that we're doing now shows that divorce can be an ACE if the parents or couple that are separating are not doing so in an amicable way. Because people can certainly separate and co-parent, and that's not necessarily traumatic. So divorce is a little bit of like a caveat population. So this basically came about accidentally in the 90s. So originally 1995 to 1997, this was discovered in a weight loss clinic quite accidentally, asking clients, about their backgrounds. They realized that some were able to lose weight and keep it off, some were yo-yoing back and forth, and some just could not lose weight, period. And they got curious as to why, and they started really asking background questions. And that became the original ACEs study with about 17,000 members over a year span by Kaiser Permanente and the CDC, asking about these childhood experiences. The original ACEs study had many flaws, the biggest being it was mostly normed on Caucasians that were in middle class that had attended college. So they had jobs, they had insurance, they were not likely to have been subjected to things like street violence, extreme poverty, malnutrition as youth. And so it really missed out a whole gigantic portion of the population. in terms of what other folks had experienced growing up. But what did they really discover, even with this sort of originally flawed study? ACEs are quite common. Nearly 2/3 or 64% of adults that do their ACEs survey are found to have at least one. ACEs lead to adult onset chronic diseases, things like cancer, heart disease, mental illness, violence. They typically don't occur alone. If you have one, there's about an 87% chance that you'll have an additional one or more. The more ACEs you have, the greater risk for these adult chronic diseases. ACEs are responsible for a huge chunk of workplace absenteeism, criminal justice system involvement, emergency room responses, and really on a population level, it doesn't matter which 4 ACEs a person has, the harmful consequences are the same. The brain really can't distinguish this toxic stress and it builds up. As I mentioned, there were a lot of health outcomes, physical health outcomes tied to ACEs, stroke, diabetes, heart disease. And they're now finding that there's a huge link between ACEs and autoimmune diseases, which just makes sense if you're looking at the studies. Autoimmune response is an over response of the body to triggers. And for folks who have had chronic stress and ACEs in their lives, their body turns around and unfortunately attacks itself. So if we're talking about things like fibromyalgia, chronic pain, arthritis, severe headaches without any sort of concern in the brain that would cause them, these are unfortunately linked to ACEs. If you're talking about children that are experiencing ACEs, nearly 3 times more likely to repeat a grade if they have ACEs exposure, 5 times more likely to have emotional, behavioral, or developmental concerns such as ADHD, anxiety, depression, OPD, a lot of those things that our youth are labeled with in school systems. For children who have 3 or more ACEs, they're more likely by 4 times to have developmental delays. Children who have 4 or more ACEs are 12 to 14 times more likely to attempt suicide. And unfortunately, that statistic carries through into adulthood as well. And children who experience 6 or more ACEs, studies have found that their lifespan is shortened by 20 years. So that's huge. Unfortunately, we're also finding a link where females are 50% more likely than males to have experienced 5 or more ACEs. So there's a lot to be said. And this is data just within the United States. We're not even talking about around the world. For New Jersey specifically, in 2016, over 40% of children had experienced at least one ACE. 18% were estimated to have multiple, and 33% of children under 5 years old had experienced 1 or more ACEs. So this is very relevant to our parent population as well. In some ways, and we'll talk about this a little bit as we go through, we can be victims of how we were parented, but also if we look at that strengths-based approach, we can apply some of that information and choose a different path for our parenting. I do want to just mention that ACEs really are disproportionately affecting our communities of color. So if we talk about BIPOC, Black, Indigenous people of color, ACEs are inherently affecting our BIPOC communities more. And a lot of that has to do with stigmatization and racism that are institutionalized. So if we're talking about the US, white people in the US have about 13% the net worth of Black folks. And the average Black family would need 228 years to build the wealth of a white family today. This is according to research in 2016. So I know I mentioned some systemic concerns such as redlining. They've historically limited opportunities that our BIPOC communities have to access things like real estate, better school systems, and to accumulate wealth. With that in mind, the new ACEs are really trying to look at and expand to encompass exposure to violence outside of the home, living in unsafe neighborhoods, homelessness, race-based discrimination, and we're trying to factor this in. So now the National Survey of Children's Health, which is a yearly national representative survey for 0 to 18-year-olds, they've started to include a question specific to this. To the best of your knowledge, has your child ever been treated or judged unfairly because of his or her ethnic group? Because again, they're recognizing that this is a concern. And so we want the new ACEs to encompass 3 areas: the household, which are all those original ACEs that I mentioned, the community layer, which is things like substandard schools, historical trauma, food scarcity, poverty, and also environmental factors, right? Like climate crisis, flooding, earthquakes, these type of things, because there's a link between where we've marginalized communities of color and their exposure to climate crises. And these things are growing hand in hand with each other. And the last piece I wanted to touch upon before talking about how this wraps in specifically to the maternal health population is a concept called intergenerational trauma. This study really initiated with World War II and descendants of survivors of the Holocaust. And we realized that there was inherent trauma passed down generation to generation. However, if we're looking at the United States, the same can be said for descendants of slavery, for descendants of our Native American populations that were forced onto reservations and subsequently maltreated for decades, centuries really. And so we're doing a lot more studies around this idea of intergenerational trauma. Psychohistorians at Psychology Today define intergenerational trauma as the unconscious transmission of trauma from one generation to the next. This intergenerational trauma affects groups of marginalized individuals far more than those of Caucasian descent. And so we really always want to focus in on these disparities. The last piece I want to mention in regards to ACEs and maternal mental health, there was a recent study done by Nicole Racine et al. And it talks specifically about maternal adverse childhood experiences in infant development. So analysis from their study revealed that there is an association between a mother, so maternal ACEs, and infant development. And they found this through two different ways. There's a biological health risk, obviously through pregnancy, if the mom is experiencing any of those chronic health concerns I mentioned before, but there's also a psychosocial risk. So if the maternal figure, the mom in this situation, has experienced a lot of ACEs, that can certainly carry through to how she parents her children, and that can in turn create additional ACEs. So the authors of this research suggest that children of mothers who have been exposed to ACEs are at an increased risk for a multitude of poor health and developmental outcomes, including delayed achievement of developmental milestones and increased likelihood of parent-child conflict. So really the takeaway in regards to this is we have to know where we're coming from to make strides forward. And we know that maternal health and psychosocial well-being in pregnancy, before pregnancy and beyond, are key targets for intervention, and why I'm so happy to be here today with Sarah and Tennille to hear, what their program specifically can help us with all of this knowledge.
Thank you so much, Jen, for really shining light on adverse childhood experiences and how it's impacting the maternal population. As we can see, it's very prevalent, and so all the work that we're doing to support our clients is very meaningful and very powerful. So Sarah, we have a question for you. Can you tell us a little bit about screening for the perinatal mood and anxiety disorders, like before, during, and after pregnancy?
Sure. So one of the first things that we do when we, first start talking about, PMAD, so that's the perinatal mood and anxiety disorders, are screening. And how do we screen for this? How do we, first, it's kind of the first stage in this whole process. So one of the MFC program's initiative is to really provide education and training to the community about the importance of screening, as well as how to administer screening tools. We provide information about what to do if the outside provider does have a positive screen and how to best support the client. So just for reference, 75% of those who experience PMADs will actually go untreated. And that's a big part of that is because PMADs are not identified or diagnosed. So when women are screened for PMADs, the outcomes are much higher because then they're able to get services, get treatment in the correct way. But if we're not screening for it, then how are we even going to tell if anybody is experiencing these? Some of the first things that people can kind of start to recognize within themselves are, increased depressed mood, which means, lack of sleep, trouble eating, lack of concentration, loss of motivation, very similar to those of regular depression, not only in postpartum, but, any increases in mood. We talk a lot about the baby blues, and how many mothers experience that baby blues about 1 to 2 weeks after postpartum. But for postpartum depression, we're really talking about when you're experiencing those for longer than 2 weeks, and that's why it's so important to screen. When we talk about screening, I think a lot of times people are like, oh, we can get screened and maybe once or twice and that's it. But they really recommend that women should be screened for PMADs at every trimester during pregnancy and at all doctor's visits during the first year following pregnancy. That includes visits to pediatricians, OBGYNs, all the necessary aspects of the care team should be screening during those times. When we talk about screening tools, we talk about tools such as the PHQ-9 and the Edinburgh Postnatal Scale. Those are two of the most recognizable, screening scales. When we talk about, screening, the reasons why I think it's important to highlight some of the risks of untreated maternal mental health conditions during pregnancy, and as well as birth-related complications, those including low-term or preterm births, longer NICU stays, impaired bonding, as well as suicide. Suicide is actually one of the leading causes of death for women in their first year after pregnancy. So with all that being said, PMADs are treatable. We provide individual therapy, couples therapy, group therapy, as well as medication management, because PMADs are something that is treatable. And with screening, we can really better support our clients and the community.
Thank you, Sarah, for really underscoring the importance of screening and as a tool for prevention as well, and some support. So Tennille, we have a question for you. How prevalent is substance use during pregnancy?
So it's very prevalent and not talked about. Definitely hugely stigmatized, but I do have a statistic that I want to share. And each year it's estimated that 400,000 to 440,000 infants nationally are affected by prenatal alcohol or illicit drug exposure. And that is from the SAMHSA, Center for Behavioral Health Statistics. They do a survey, a national survey. So it is very, very prevalent. Again, I just want to reiterate it, not talked about, so therefore not treated. And with that, people are suffering in silence. Women are afraid to access the care they need for fear that if they do tell on themselves and talk about struggling with a substance use disorder, that they will end up in the system. And therefore, that affects outcomes. So, destigmatizing this, I think, is very important work. And just, here at CarePlus, to be able to partner with everybody doing this work around maternal health is very important. Lots of issues do come up that could trigger a recurrence in substance use during pregnancy. So it's not that somebody could be actively using, but all the things that come up, all the hormonal things. There's a lot of co-occurring clients. So that is that they're struggling with the addiction or have the history of that. And then there's mental health that they have to deal with as well. So that could trigger the addiction. So it is a very complex state, but it is treatable. And that is, I think, what the Maternal Wraparound Program seeks to do, is really give these women a safe place to, access treatment, be confident that they can come and get treated without automatically being in a system, or, there's a huge fear of infants being taken away. I also, what the program also seeks to do is give that hope that just because there has been some exposure, that does not mean there cannot be a good birth outcome. So really just giving the woman that hope and then getting them to the right places to access those services. But it is prevalent. It is normal. We know substance use is a recurring condition. It does not go away because somebody is pregnant. So why, do we stigmatize it? Is a challenge. It's a barrier for these women to get the care they need and to have a good outcome. Recovery is possible in pregnancy, in the postpartum period, and any other time, but making it accessible is, really, I think, the work that MWRAP is seeking to do.
Wonderful. Thank you for sharing. And it seems like you're really focused and determined to really help this population. Sarah, how do PMADs affect the family unit? You know, when you're thinking about spouses and partners, support systems.
I think that PMADs don't only affect the mother. It really does affect the entire family unit. When we talk about, Jen talking about ACEs, PMADs directly impact the baby and causes ACEs, as Jen was talking about. It can cause impaired parent-child interactions and behavioral, cognitive, or emotional delays for the baby. I think that when we talk about maternal postpartum depression, all of those, we also have to talk about paternal depression. It doesn't only affect the mother, it also affects the partner, spouse, and father. Actually, 1 in 10 fathers will experience postpartum depression or anxiety. And even though there is a stigma for women, the stigma for new parents, new fathers is even greater than for women, just because of the overall stigma of mental health for men. So I think that that's really important to highlight as well. Depression and anxiety are 2 times as likely for expecting fathers compared to global estimates for men in general. So some of those impacts can lead to increased anger, irritability, lower levels of affection, and higher levels of criticism. So although the postpartum depression and paternal depression come around the same time, they're kind of seen in different ways. When we talk about like the increased anger and irritability for men, it's more sadness and depression for women. So it really shows in 2 different ways. So I think that not only are we talking about the mothers and the impact that it has on the mothers, but we really need to talk about the entire family unit. And that's why at CarePlus, at the Maternal and Family Center, we really do put an emphasis on, taking in fathers as well. They are a huge part of our clientele is the fathers, working with them individually, as well as working on couples counseling in terms of communication needs for both of the parents, so that both of them can better, serve the child. And I think that with ACEs and with parent-child interactions, that's such a huge part of the development of a baby, and helping the parents first can really create that better environment for the babies. And that's really kind of what we're talking about when we talk about how it impacts the entire family unit, and pulling in different parts of the treatment team. So when we talk about us working with mental health, really being in communication with the pediatricians, being in communication with the OBGYNs, and really having that open flow of communication can really help with integrating it more as not only the mother's problem, the mother's concern. It's really a family unit, and taking that approach is something that we really strive to do in the Maternal and Family Center, and that's why it's called the Maternal and Family Center.
Thank you for talking about that and really highlighting the importance of the approach being the whole family unit to provide support for everybody. Can be very beneficial, as you shared. Jen, how does attachment theory impact new parents?
Thank you so much for asking that, Maggie, because I think that some of us are aware perhaps of how we were parented, and we may be nervous to become parents as a result. And I think that there needs to just be a little more awareness around attachment theory in general, because it seems like a very clinical thing that was just studied, but how does it affect our everyday life? And Sarah was touching upon this as well. So attachment theory, if you think about it in the day-to-day, that's the bonding, right? So that's how are you as the parent, whether you're the father, the mother, the caregiver, the adopted parent, whoever you are to this child, how are you bonding? How are you interacting with them? That's attachment theory. So attachment theory, historically, if we're looking at it, really became a very popular thing in the 60s and the 70s. So we had John Bowlby and we had Mary Ainsworth, and they sort of were like the pair that refined this idea of attachment theory. And it's a very psychological, but also evolutionary driven idea. This idea that we, of course, want our children to survive, to pass on our genetics and so on and so forth. So that's like an evolutionary look at it. But from the psychology piece, how does our parenting affect our children and how they can explore the world down the road? And so the original study really came up with 3 types of attachment. And then there's a 4th, which I'll touch upon, but the 4th is a little controversial as to whether or not it may actually exist. So this research was done in a setting where they observed parents and children interacting. And they created what they call the quote unquote strange situation, right? So the parent leaves the room, and a stranger who was part of the study comes in and interacts with this child, and they see how does the child react to the stranger. And then the stranger leaves and the parent comes back. And equally important, how does that child now interact with their parent that came back, right? So it was both pieces of that. How do they interact with the stranger? How do they interact once reunited with the parent? And from this original study, they came up with 3 types of attachment. Securely attached children, that's sort of like the aim. If we could all be securely attached, right, that would be fantastic. Those are children that were able to explore. They could play with this random stranger that came in. They could play with other toys. They weren't like stressed about it. And when their caregiver came back in, they were like, oh, yay, the caregiver's back, right? My parent's back. And they were excited. This was a secure base. So this child had a secure base to their attachment figure. They could interact with the world, but they always knew that their parent would be there. And so they could come back in a safe way. So that's secure attachment. We have anxious ambivalent attachment, which also maybe you may have heard of it as resistant attachment. In general, this is a child who doesn't typically explore when the parent leaves. They kind of like sit where they were. They're wary of strangers. Even when the parent's there, they're looking at strangers like, I don't know what to do with this. When the caregiver departs, the child is highly distressed. You can see it, right? There's crying, there may be screaming. And then when the caregiver comes back, though, interestingly, they're ambivalent about it. They realize that their caregiver is back, but they don't settle. They don't feel secure. I want to say that this is different than around week 29 in general. When you have a youth who's 29 weeks of age, they go through this lovely phase of stranger danger where they dislike everyone that's not their parent. That's typical development. It lasts, a few weeks, and that's part of a typical development. This is different. For children that are beyond this developmental milestone, they are still interacting this way. So if we look at the anxious avoidant pattern of attachment, they will show little emotion when they're reunited with their caregivers. They feel like their caregiver is not a secure base, whether they're there or not. And so these type of youth will actually avoid a lot of social interaction, and you'll see this throughout their lifespan. They will just be rejecting of situations and not have a secure base to come back to. And that leads us to the last type of classification, which is the newer one. It's called disorganized. Really, the reason it's called disorganized is because there are some youth who don't fit neatly into either of the previous 3 categories. And they just feel like some situations they react different ways. This is a controversial category, though, because most of us typically do have one preferred style. And of course, we react differently in different situations, but we typically have one preferred style. This is really important information to know. And again, if we're looking at a strengths-based approach, if we take an assessment of how we were parented and perhaps what our attachment style is based on how we were parented, how can we change that for if and when we want to be parents? Let's say you had an avoidant attachment style based on how you were brought up, and you're thinking to yourself, oh my gosh, what happens if I have a child? Am I going to create the same situation? And exactly as Tennille and Sarah have been saying, no, your future doesn't have to be written and defined by how you were parented and by things that have occurred in the past. So let's find a better way. But it starts with truly understanding what this means for you, taking that information in, and then deciding how that can inform your decisions as a parent.
We appreciate you sharing all that education, around attachment theory for, our listeners here today to really understand, maybe connect with their own experiences and how they can digest that information. We really appreciate that, Jen. So Tennille, what are the barriers to accessing substance use disorder treatment during the perinatal period? You just touched a little bit about the stigma, but what are some of the other barriers that this population is facing?
Yes, I have a list. So, there are unfortunately a lot of barriers to service. I also am very aware that that is why my particular program exists. But, just to start, I would say fear and shame are the biggest. Barriers are both internal and external, but those are usually driving forces behind why women do not seek substance use disorder treatment during pregnancy. They struggle alone. I think time is also very interesting. When somebody is actively using, you a lot of times think you have more time than you really do. So that urgency goes away, and people are trying to handle it themselves. And again, just based on traumatic experience maybe in the past, what's happened, if this is not your first child, really trying to control it and not letting people in might feel like the safer choice at the time. So I think, fear, shame, denial, lack of coping skills. If I'm not using, what else is there if I'm not established in my recovery? Lack of emotional support. Talk about ACEs. A lot of the women I work with, yes, this is a generational thing that they're experiencing. They don't even know where to start. Maybe they have people who are actively using their life. They don't know what it looks like to be not associated with any substance use. So really don't know what that is. So there's no emotional support from family or a recovery community. Strained relationships. Unfortunately, there's a lot of domestic violence type situations. When people are involved with substance use, housing issues, financial issues, just not knowing how to link to health insurance, issues with transportation are huge. Just simple things like not having identification ends up being a huge barrier. And I have to say that is one thing that case management services do very well. There are certain laws, and there's just one of my favorite in particular in New Jersey. If you're homeless, you actually get a free non-driver's license. They will pay the fee if you're working with an agency. And same thing with birth certificate. So, because these are a real barrier. I've worked with women who are trying to access MAT, and they are turned away because they do not have identification. And this is late in pregnancy. We have about 8 weeks left, and this is the barrier we're facing. So these are the kinds of things that, advocacy within this program work on. Also, when you do get to providers, having providers that understand what substance use looks like and will not create additional trauma while people are going through this. Finally getting somebody there and then having a very negative experience with a provider is a real thing. So actually attending these appointments with women are something that we do to make sure that we're there and they feel safe and advocated for. So, there are unfortunately a lot of barriers, both internal and external. That advocacy piece, teaching clients to advocate for themselves, normalizing that this is hard and they may not know what to do, and that these are all learnable skills. Really being aware, that was great, Jen, what you shared, on attachment style, because none of this is set in stone once you're aware. Getting to the resources that can help you do something differently for your children. That's why a lot of moms come in, right? That's that impetus. But also for yourself, you can still change a lot of it as an adult for yourself. That I love the phrase reparenting yourself. And sometimes this is an opportunity for them to do that. So the barriers are numerous. And it's why I enjoy working on this program so much, because we really do aim to tackle that and work on that and advocate for a better way of serving women.
Sounds like you're doing a lot to provide that advocacy and to provide that support. It's a wonderful program. Sarah, what are some of the factors or challenges and barriers that have come up during COVID that have impacted, the clients that you're serving?
I think that it's impossible to really talk about anything with mental health without mentioning what's kind of going on in the environment around us. So the Maternal and Family Center, the inception actually began in the middle of COVID, and we really started to see clients during COVID. So that was kind of our first clients came with COVID actually. So we've kind of been on the front lines of COVID the entire time. So for everyone kind of listening, maternal and mental health conditions have actually tripled during this COVID-19 pandemic. And pregnant and postpartum women are experiencing anxiety and depression at a rate of 3 to 4 times higher than they were prior to the pandemic. I stated a fact earlier that 1 in 5 women are experiencing PMADs, and now before the pandemic, it was actually 1 in 7. So you can see that number and how much it has changed, from COVID within the past couple of years. There was a study that was conducted, it was called the PEACE study, and it was launched to really better understand mental health and well-being of being pregnant during the COVID pandemic. And it surveyed about 1,123 women, and more than 1 in 3 or 36% reported clinically significant levels of depression. And before that, the rates were about 15 to 20%. So I just kind of say these statistics to kind of put it in everyone's minds what change really happened from COVID. And I kind of wanted to highlight some of the things that, the women have actually said to me and the members of our team. One of the biggest themes that COVID has kind of created was the feeling of isolation. So challenges this challenge kind of existed before COVID, pregnant and postpartum women do kind of feel isolated, on their own. But it's really been exacerbated by this pandemic. And the feelings of isolation that I'm kind of talking about are having to go to doctor's appointments alone. That was never a thing before COVID. And now some of these women are really having to go into, getting ultrasounds alone. And that not only has an impact on the woman, but also on their partners. The partners not feeling like they are connected to the pregnancy, not connected to that. That can really create a feeling of isolation on both sides. During birthing, having one or no members of your support system in the labor and delivery room, an unexpected birth plan, something like a C-section that you weren't expecting, without having your support system there, that can be very traumatic for a woman. And if you're expecting, like when you're thinking about your birth and, in the future and thinking about like having your parents there, your partner there, and having multiple people there, and it's only one person, it can really change kind of the experience that you had and that you could have had. So that's just one, aspect of the isolation, within the doctors and hospital realm. But then also the feeling of isolation of being stuck at home and not having your extended family, your extended support system. There, in the peak of the pandemic with all of the fear and the ambiguity, a lot of these families were kind of stuck only within themselves, and they didn't have that, the village that everyone always talks about, having that huge support system around them. Because of COVID, they weren't able to get that. And, that can create a lot of feelings of being isolated. It can increase tension between a relationship because you're not able to get outside of your house, not able to get outside of your relationship, doing things outside, like coping skills, going out to lunch, going to the movies, things like that, they couldn't do anymore. And, that feeling of being stuck inside a home for even up to a year because they didn't want to put their baby at risk, they didn't want to put themselves at risk, while being pregnant, that really created just a genuine sense of anxiety, fear, increased depression. And that's kind of where those numbers are coming from, some of those other things. So I just wanted to highlight a couple of things that we've heard in terms of COVID. And, with kind of the opposite side, COVID has allowed for telehealth and allowed for increased access to services because of telehealth. And the maternal mental health field has really, been helped by the telehealth services. Being able to have your baby with you and, seek services has really been a access point. So when we talk about COVID, I think it's really important to talk about all aspects of it, and the increased, level of telehealth services has really been very helpful to some women who may not have been able to get services in other circumstances. So those are just some of the, impacts that COVID has had on this population. And I know that it's going to be something that continues to be studied, continues to be researched.
Definitely. Yeah, it's interesting to note, that COVID really has taken away a lot of our go-to layers of comfort. And then you're adding on pregnancy can bring on a lot of fear for women, which it seems like, and the whole family unit, as you all have been talking about. But I do really appreciate you highlighting some of the positive outcomes of COVID, just shifting our energy and shifting our focus to what are some of the benefits that come out of it, and improving access to care is huge. So that's a great thing to highlight. So Tennille, how do we effectively provide support to pregnant women with substance use disorders to really improve their outcomes for their exposed infants?
Yeah, I think that it definitely is a recovery-oriented systems of care kind of approach. And it's not one thing I think that's going to help. It's really getting women connected, being that what I feel like MREP is that point of contact where we can connect women with the larger resources they need. So whether it's basic needs like food, connecting with safe shelter, clothing, infant clothing, right? So when you're getting ready for a new baby and the money is low, or you're laid off because of COVID and all these other things, where can I go for that resource? So it's things like that. But it's being the hub and really getting the women to recovery friendly support services. So mental health, the Maternal Family Center is wonderful because it is specific to their needs already. It's a warm and fuzzy feeling when they're saying, oh, there's a program for me. Connecting with trauma services, having that right in-house to be able to have somebody to help them navigate. As I function as a peer on the team. So one thing that I like to do, the larger community is important too. It doesn't seem to just be counseling or trauma services. It seems to be a more ongoing solution and connecting to a recovery community. So it might be a 12-step meeting I'm introducing people to. It might be smart recovery. And just to kind of bring up, that has been severely impacted during the COVID crisis. Everything is virtual and some people have opted out. And one thing I had feared that so much in the beginning. I can't imagine somebody trying to start recovery in this climate. So really any chance I get, really connecting them to a live meeting, because some of them did make it through the whole pandemic. Hard to find, but to really just, I think that's where you start just connecting people with all recovery friendly services in the community, women specific for this population. Because I think there are a lot of extra needs. There is a lot of stigma. I'm pregnant. Why am I not happy? Everything's supposed to be perfect. Then there's a whole thing, some people have that pressure. You're a substance user. How could you let yourself get pregnant? So, I think that there's just very specific dynamics. So I think supporting them, the way we do that is really having as many resources specific to the care of women who are experiencing mental health issues and substance use issues, because it is, there's so many different considerations, just even access to treatment. We're looking for a mommy and me. We're not just looking for rehab. We're looking for a mommy and me if there's an active issues. And those are not, they're just not as numerous as I think we need them to be, and not as easy to access. So I think that working together, collaborating, that is how we support, effectively support women in the prenatal and postpartum period.
Thank you, Tennille. And we're definitely going to touch upon that collaboration and integrative approach in a quick minute. Before we go to that, just one more question for Jen. Can trauma be related to the perinatal population? And maybe you can speak to a little bit of some personal experiences as you are a new mom.
Yeah, absolutely. So trauma 100% can be related to all of the stages of trying to conceive, being pregnant, delivery, postpartum. I think the thing with trauma is it's important to remember that outside folks can't define what trauma is to an individual. Trauma is an individual experience. What I might find traumatic, somebody else might not, and vice versa. So trauma is defined by the person experiencing it. So if somebody tells us that something was traumatic to them, then it was trauma. We don't need to get hung up on, was it a big T trauma? Was it a little T trauma? It doesn't matter. It's the person's experience. And I think what Sarah and Tennille have been mentioning and what I've really been hearing, in thinking through their programming and what they offer and what CarePlus offers is exactly this. It's not up to an expert to define what is traumatic for a parent, for a child, for anyone. It's up to those folks to tell us. Speaking from a personal lens, my husband and I decided to try and have a child during a pandemic. So yes, we went into it knowing it was going to be a sort of bizarre experience, but nothing prepared us for what it actually was. We haven't quite touched upon it yet, but conception can be very traumatic for folks who might be struggling with infertility. 1 in 4 pregnancies, unfortunately, does end in a miscarriage. That does not mean that 25% of women are going to experience a miscarriage, but 25% of pregnancies overall can end in a miscarriage. And that did happen to me. Prior to having our daughter now, we did have a miscarriage, earlier on, and you felt very isolated, of course, because I think a lot of moms internalize this as like, my body was failing. What did I, quote unquote, do wrong that caused this? And obviously it's not something that a person caused for whatever reasons, medically or whatever, the pregnancy was not able to go full term and it spontaneously ended. And that's a very scary and traumatic thing. So that's one area, that I imagine, like Sarah and Tennille, they may also get a lot of clients in their programs with past histories or currently experiencing. And that's super traumatic. Whether you already have a healthy child or it's supposed to be your first, it never quite prepares you for it. For those who have experienced miscarriage, when they are, quote unquote, finally pregnant, you kind of carry a lot of that throughout your entire pregnancy, that fear of like, oh my God, is it going to happen again? Right. So then you may experience this thing where the whole 10 months, by the way, they tell you it's 9 months, it's 10 months. You're pregnant basically 10 months. Sorry, everyone. So the whole 10 months you're thinking about like, oh my gosh, is this going to happen to me? And you're in a pandemic. And so you're really limiting your exposure to people. You're not wanting to bring about anything that could potentially, impact that. So that's certainly traumatic. Regarding birth, this is a very traumatic process in general, regardless of whether it goes perfectly as planned. Like I hear a lot of this, like, my birth wasn't perfect, it didn't go as planned. And I hear what people are saying. Sometimes I chuckle to myself because I don't think that any birth ever does, go specifically as planned, but that doesn't negate that for some people, things really drastically change. It was not my specific experience. I chose to go into this with like, I don't have a plan on purpose because whatever had to happen, and that's what we did. But I know a lot of my friends and counterparts were pregnant around the same time as me. And a lot of them had very specific birth experience. I want a natural birth. I want to do meditation while it's happening. I have certain playlists and all of these things. And I have friends that had very specific birth plans. And it turns out that their child was breech. And then they had to have a cesarean. And it was like, you have to have a cesarean now, like we're going. And I can't even imagine how traumatic that must be because you don't even have a chance to like think about it and you're there, and that's not the birth that you wanted nor planned. And even if it medically was the right option and logically people know, yes, medically this is the responsible option, it doesn't take away the emotion of this isn't what I wanted, right? So birth is very traumatic. As Sarah and Tennille have both been mentioning, postpartum, even in a perfect world, without COVID is hard. Pre-COVID, certainly that saying it takes a village is 100% true. You have extended family coming over, your neighbors are maybe bringing you dinner. You are like, oh good, my parents can watch this child so I can just leave the house and not hear crying, all of those pieces. A lot of that doesn't exist in a pandemic world where you have this child who is not immunized against anything. And you can't expose to just everything. So you really are parenting on an island. And that's not how humans evolutionarily are supposed to be. We're a very social creature. We survive among support. And without that support, it's like another layer is taken away. I know Sarah mentioned PMADs, and they have just been increasing, during COVID. I eventually decided that I needed help. And it turns out that I'm, diagnosed with postpartum OCD, obsessive compulsive disorder. Very rare, as Sarah knows, in comparison to some of the other kind of more widely known postpartum anxiety, postpartum depression. These are all very real. Again, not negating what other folks are going through. It was challenging because I'm a mental health clinician. I quote unquote should have known better, right? And I struggled until finally people around me were like, I don't know, like, I think you need help. There's more going on here. And then I was in a space where I could finally hear that, and get that help. But like Tennille mentioned, parents sometimes are really worried. What is the system going to think, or the system going to maybe do if I bring this up? For myself, being a mental health clinician, obviously I've had to work with DCPMP. I've had to work with other systems. They do fabulous work. I'm not trying to say that they're, not a good entity, but when you're on the other side of it and you're going and you're saying, yeah, I have a newborn and I'm having intrusive thoughts, you worry, what does that mean? Could my child be taken away? So these are all very real things. And I think that society is getting better about being real about a lot of these things, but we still have a long way to go. Like if you look at social media, there are a lot more accounts and people being very real and saying like, I'm struggling, like I need help. This is what's coming up for me. But unfortunately, we do have other accounts and platforms we might look at where they're portraying motherhood as a very easy thing. That's natural and there's never any problems and there's something wrong with you as a mom if you feel overwhelmed. And if that's their actual experience in life, like fantastic, please bottle that up and give it to the rest of us. But I think it's doing a disservice. Like if we were all just honest, like I'm struggling, I'm here, throw me a lifeline, and then somebody actually threw you a lifeline, that would be a much more authentic and better place to be in. And specifically why everything that Sarah and Tennille are mentioning is so necessary. We need peer recovery. We need people that have walked in those same shoes as us. We need clinical experts, of course. We need family, we need support. And honestly, we just need parents to be real with one another. And I think that's a lot of how you begin this conversation of integrative care and integrative approaches.
Thank you for being so genuine and open with us, Jen. I'm sure our listeners, and I know all of us here, are very appreciative of that. And I think that's a great way to kind of close for our discussion today, of really touching upon that idea of collaboration and integrative care. And, maybe somebody else can add in and speak to the importance of that.
I think that the maternal and family center specifically would not be able to run without integrative and collaboration. When we're talking about MRAP and the experience that peer support can give to some of the women who are struggling with substance use, we have a team of experts in terms of the perinatal population, and we pulled in teams from our addictive services, and they were trained as well in perinatal mental health. So bringing that side as well as the MRAP can really serve this population that I know that Tennille really highlighted is very underserved and doesn't get the attention that it really needs to get. So the Maternal and Family Center leaning on programs like that and those peer supports can be exceptionally helpful. When we talk about trauma and training not only the team, but the entire agency on trauma, that can really be impactful for the maternal mental health field. Trauma is something that is very prevalent within the maternal mental health field, and having experts like Jen and the VTTC program to lean on when we need to collaborate, when we need to discuss some cases with, multi-level trauma, it's very, very helpful to have those. And I think that because the Maternal and Family Center has clinicians, we have our medical expertise, we have prescribers like psychiatrists, we have advanced practice nurses, so on and so forth. We have our outreach staff who outreaches to different hospitals, advocacy groups, PCPs, all of those different providers, so that us clinicians can, and the prescribers, the psychiatrists, the advanced practice nurses can really collaborate with those entities, talk to the OBGYNs, help get blood results, help get them the services they need, make sure that they are scheduled to come to appointments, all of these different facets. It creates this multidisciplinary team and really can get these women and their families the services that they do need and the wraparound care, so that not everything is on its own island, everything is kind of together. And I really think that that's important.
Yeah, I just wanted to add that, collaboration, one of my favorite things about it, if, you're practicing it, it makes things easier for the client. One thing I think about this, we've all brought up and what we've talked about, how difficult these periods can be in someone's life. So just pregnancy alone. So that's without substance use, that's without mental health, without anything, just that period alone. And what collaborating helps too, it's you kind of become a place where this person knows they can get their needs met. Sometimes I've heard from my clients, it's hard to make one call. Having a list of providers to call is hard. And what I'm able to do in my role on MRAP is sometimes, if I'm hearing that overwhelm, say, okay, I can reach out to, your provider at our addiction services if you're working with a clinician, or, I can reach out to your case manager, just help them in the moment and in the day. So I think collaboration is so important that way, just to make it easier. So with internal and external providers, that's why community partnerships are so important. And we do a very good job of that. I know we all do at CarePlus. So I just think it makes it easier for the client to be kind of that one-stop shop, so to speak. But yeah, I think it's key. And another thing I like to do in my role for collaboration is, sometimes clients are new to mental health treatment. A lot of my clients have only been through, and if at all, substance use treatment, which has been different, traditionally. So sometimes even being able to have a conversation with them about what to expect when you're going in to see a counselor. How does a case manager work with you? You're actually teaching them, skills for life, but how to collaborate. Sometimes they don't know how to collaborate either. So, you're in this unique position to really teach them, where you can go to get these needs met, not just for now, for a lifetime.
I really appreciate, I really love that perspective of collaboration makes it easier for the client. That's very, very important to really highlight. Thank you all. This has been amazing. We've learned a ton of information, and you shed light on a lot of the issues and the crises that are happening, for this population in our world today. So before we leave, I'm just wondering, how can our listeners and participants get in touch with all of the programs that you are working on at CarePlus?
Yeah, so I'll say for the Bergen Trauma Training Center, obviously we're a little bit more involved in the training piece. So certainly if schools or organizations or anyone is needing certain training on topics, the best way to get in touch with us is via email. And we'll make sure to include, the emails in the chat information, but my email is Jennifer, K-A-P as in Peter, @careplusnj.org.
Thanks, Jen.
For the Maternal and Family Center, we do have our program coordinator. Her name is Lorna Gazik, and she can be reached. I'll provide the information in the chat so that everyone can just kind of copy and paste. I think it's a little bit easier. And our process is you can get in contact with Lorna, and Lorna will send you up with an intake with one of our intake specialists, and then our intake specialist will help link to any services that they find that you might need, including individual medication management groups, as well as anything such as like housing, if they need case management services, benefits. We can really kind of link to any type of services within CarePlus, and if needed outside of CarePlus. So Lorna Gazik is our golden person, and she helps with everything with that. So that's the contact for the Maternal and Family Center.
Thanks, Sarah.
Okay, and for maternal wraparound, it's going to be me because I'm the coordinator. Email is fine. My email is Tennille J at CarePlusNJ.org. I am also very big on my work cell phone. Sometimes text is more comfortable. I hope somebody who needs this is seeing me. Feel free to call or text this number as well. It's 201-321-5278.
Thank you, Tennille. And thank you all for your expertise and maternal mental health, and really shining a light on integrated care as a solution. And for our listeners who are watching on other streaming platforms, please feel free to leave any questions or thoughts that you may have, as we'll be periodically checking to provide updates and to provide resources for you all. So we appreciate your time being here with us in honor of Maternal Mental Health Awareness. Take care, everybody.